Good afternoon, and thank you for joining us again for the Chatham House COVID-19 webinar series with our distinguished fellow, Professor David Heyman. Today we're looking into what's going on in India. There's a lot of global interest in India's experience with the pandemic at the moment, with the official death toll passing 300,000 this week, an oxygen supply crisis, slow vaccine rollout, scores of other challenges, and news of a deadly black fungus epidemic among COVID patients. With us to explore these issues facing India and the implications for the world are two leading experts in the area, Sujata Rao and Ramanan Laxminaraya. Sujata is a former Secretary of Health and Family Welfare in India who's been commentating on the pandemic, critiquing government policy and advising state governments on their pandemic response. Ramanan's an economist and an epidemiologist, and he's the director and senior fellow at the Center for Disease Dynamics, Economics and Policy in Washington, DC, but he's based in Delhi, New Delhi. He's been a leading epidemiological modeler in the pandemic. So it's a real pleasure to have both of you here with us today. Thank you so much for joining us. I'm going to do the housekeeping bit to start with. The briefing is on the record. There'll be a recording afterwards that'll be on YouTube and the Chatham House website. I do encourage you to ask questions of the speakers. You can do that by using the Q&A function on Zoom, and upvoted questions are more likely to be selected. So please do upvote questions that are similar to the one you might want to ask. Right, so we're going to dive in, and welcome to you both, and it's great to have you here. So Sujata, I was hoping we could start with you on really an overview of what's going on with the pandemic in India right now. There's been a lot of coverage in the media, a lot of attention to it, but it seems to be moving quickly as the pandemic does. But if you could brief us on what's the situation now? What are the biggest challenges the country is facing in controlling the virus? And how is the country approaching its response?
Thank you, Emma. At the outset, I would like to thank you and Chatham House for having me here this evening. Well, coming to your question, right now, we seem to have got over the hump, the peak, and the pandemic seems to be, the virus infection seems to be coming down. We had almost a week to 10 days of very high caseloads that crossed over 400,000 a day, and with deaths more than 4,000 a day. So today we have about 200,000 cases, but then we must remember that these caseloads have been reducing in the context of nearly the whole country being under a lockdown. So that has made a big difference in us being able to disrupt the transmission rates and get our caseloads well under, some sort of a control, much better than what we had before. But what is worrying is that almost 6 states, large states, Maharashtra and nearly every southern state and West Bengal, they seem to be having a positivity rate of more than 20%. That's worrying, that's huge. But then Delhi has done well. It had more than 32 at the peak time, had more than 32% positivity rate. Today it's fallen to less than 5. It's about 4.2 or something. So there is some amount of improvement in the states. But as I said, these 6 states are still peaking. Whether it will continue to be they've peaked already, or they're going to still climb higher, say in Tamil Nadu and Karnataka, or is it coming down? One can't tell, one has to wait. But right now they're still clocking in 35,000 cases a day, which is quite high, and more than 22% positivity rate. And the testing, they're keeping up the testing rate quite high. But the other states, barring these 6, the rest of them are between 2 to 5% positivity rate. So we still haven't reached the hallmark of less than 1%, where we can sort of relax and say, okay, the pandemic is kind of slowing down really significantly. Now, every modeling exercise tells us that unlike before, this time, because if you remember, mid-September, we had peaked to 98,000 cases, but by October, we had sharply reduced. But they're saying that this time, the wave 2 is going to take its own time coming down, and we can expect some amount of a more decent figure like 16,000 or lesser only around the end of July. So that's a long wait, June and July. Now, deaths, though the caseloads have been coming down, the deaths continue to be high. They've crossed 4,000 a day. Today, it's more than 3,500 a day. But but what is really worrying are two factors. One is we don't seem to know enough about what's happening in the rural areas of the northern states, particularly UP and Bihar and these highly thickly populated states of India. And that, I believe, is going to be a challenge, which I'll come to a little later for your second part of your question. But coming down to seeing what is the new features of wave 2, what we found here is that compared to wave 1, more number of younger people and the penetration into rural areas, these are the two new features that we find as compared to wave 1. Now, coming to your second part, what are your biggest challenges? Rather than challenges, I would say, what are the policy options which need to be addressed very urgently if we want to contain this pandemic from again going up, or as they're predicting a wave 3, but a wave 3 which will be more benign than what we have faced in wave 2. We will need to look at three, in my opinion, three very significant policies, which are also challenges, if you might put it like that. One is a close and a very rigorous research agenda to use this time when the pandemic, when the caseloads are reducing and the pandemic seems to be getting under some sort of control, is to really look at our data, which we need. Because right now I get the impression that we're just fighting this war blindfolded. We don't have enough of a grip on the data. Midway wave 2, we decided that, we discovered that it was B1617. Now, we should have known that, what's happening in UK. We should have known how wave 2 was affecting other countries. We should have known that a wave 2 must and was to be expected. How is it that we were caught off guard? So we need to do a much greater dive down into our data. We have plenty of data today, whether it's data on vaccination, which I will come to a little later, or whether it is data on where the deaths are taking place, because I do believe there's huge undercounting. Today we are saying we have done about 28 million cases and about 300,000 deaths. I'm quite sure, and I wouldn't be surprised if it was double the number of cases and double the number of deaths. And we need to know that. We need to know that and not push it under the carpet because it's politically convenient for us. So it's very, very important that, there is that the data analysis and data research is insulated from any other externality like a political concern, and a very rigorous review of every parameter is done. It is brought out into the public. We have wonderful researchers, we have wonderful institutions. We should just draw the best brains, the epidemiologists, the public health, the biostatisticians, all the experts, and in fact, even invite experts from around the world, if required, to help us analyze this huge amount of data to say, where are we? What is our future going to look like? And how do we contain this pandemic? Because it is not going to be possible for India to fight and put up a resolute fight if this were to go into the rural areas of the northern states and northeastern states. The systems, the health systems are extremely fragile, and we will have a calamity on our heads if really what we saw happen in Bombay and Delhi were to happen in those states. We cannot afford that. So we need to know the actual number of deaths that have taken place over there, and we need to take policy actions to really tackle that. The second most important is, of course, as you know, even David has been advocating mask and social distancing and hygiene. Well, social distancing and hygiene is quite tough to implement and enforce in a country like India. But mask wearing and behavior change towards that is something that we need to rigorously enforce, and that needs a huge behavior communication campaign to be launched. And I'm afraid Government of India has not done enough on that score. I think that should be done as we did for HIV/AIDS in promoting condom. That was the only barrier for infection, just as mask is a very effective barrier to infection in this case. The third is, of course, related to prevention strategies is vaccination. I'm afraid we have bungled up on that score. We are now trying our best to make up for the lost time and get as rapidly as possible to get on top of the situation of the vaccination deficit and vaccine deficit, and try and do. I mean, government is really now bothered. It has understood that there is a lot, but the policy mix itself is quite confusing. And that's a very big subject. And I don't know if you want me to get into that issue, but we could. But what I would like to say when I link it up to my first point of data research is recently we revised our, the Covishield is a very popular and mostly used. Covishield is AstraZeneca. We call it Covishield in India. And that is mostly used in India because they're supplying us 65 million doses a month as compared to the second vaccine that we have, which is only about 10 to 15 million doses. So it's basically AstraZeneca that we are dependent upon as of now. So till now, we had a 2 months period from the first dose to the second dose. Then we revised it about 2 weeks ago to say 3 weeks to 4 weeks. Of course, partly also on grounds of inadequacy of vaccine and covering more people with one vaccine. But why I'm saying data is so important is the findings that Public Health England has just come up with, saying that the first dose only gives, of course, the variance is quite, the confidence levels are quite wide, but nevertheless, whatever the sample size and whatever their survey was, showed a 33% efficacy for the first dose. And the second dose given after 2 months or so was about 59.8 or 60% efficacy. Now, if that is the story, that means, I mean, we take 50% as a goal, as a hallmark for efficacy of a vaccine. Giving first dose of AstraZeneca, which is almost 12 million people we have covered, or 10 million people we have covered in the 10% of our population we've covered in our country, is really of no use if we are going to keep them waiting for the next 3 months. So this kind of data is what we need. And why do we have to depend on UK for these insights when we have vaccinated more than 190 million people with this? And our genomic sequencing is very inadequate, therefore. So, we have done hardly 1%. I think, David, you believe that we should do 5 to 10%. In your last presentation, I heard you say that, but we have just done about 1 or 2%. So, and I'm talking about the efficacy of Covishield against 617, which is the predominant strain that is right now all over the country, except the few northern states where we have BA.1.17. But I'm talking about the dominant strain that is right now being faced by us. So these are the sort of issues that are very critical for us to look at, because now we are going to get a window period. As this pandemic wave 2, I'm quite sure that it's going to come down. The peak is over as far as I can see. And before a wave 3 comes up again, I really think that we ought to give data and data analysis and expertise to be brought in of the right kind, and get our strategies much more focused and much more evidence-based than what it has been so far. So I think these are the challenges that I would say. And the country's response, as you've seen, has been a bit, I wouldn't say, it has, first it started with hugely centralizing the whole process. But now they have realized that, we need to really decentralize further into the states and load below down if required. Much more needs to be done on strengthening the policy response, of making it much more inclusive, allow more civil society participation, much more anchor it on the community and community participation, decentralized to local areas and local governments, because it is not going to be possible for Delhi to sit and say where my vaccination site should be or who my vaccinators should be. That kind of centralized approaches don't work in controlling a pandemic. So I think that they have realized now, and I hope that the policy responses will get more refined with more data coming in and more data analysis coming in, which is done more rigorously. I'd like to stop there, Emma, and maybe we can carry it forward again.
Okay, no, thank you, Sujata. That sounds like a very comprehensive accounting for what's going on there. I just had one follow-up on that as to whether there is anything special in India that is driving this, of who's getting sick and who's dying. I mean, I heard it's mostly the middle classes in the cities that are most affected, maybe even women. Is that true? And if that's true, why do you think that is?
You know, like, I can't give you an empirical based answer to that, because I really don't know out of these huge case loads, how many are, I mean, we've added about 150,000 cases in a flat 1 month, and how many of them are middle classes or low. But we certainly know that they have affected the middle classes like it didn't happen in wave 1. And that is a fact. And, you know, in wave 1, we were really worried about slum populations and so on. But this time, it's really gone directly into the homes of the middle classes. But that is all a consequence of the enormous amount of complacency that we had allowed to be ourselves to be set with. And, you know, when the caseloads came down to less than 16,000 and below, and deaths had really crashed to nothing much. And there was this feeling of exceptionalism, because in the media and in our own policy dialogue, we would keep comparing India's performance with the Western world. We kept comparing ourselves per million to compare to US, compared to Italy, compared to UK. Well, of course, we always did better. You know, the deaths are 110 per million, whereas in UK and USA, it's much, much higher. So we felt we were doing very well. But we should have been comparing ourselves with Vietnam, with Thailand, with our neighborhood, to say that why is it that we are having much more of this impact of this COVID-19 in India as compared to, say, our neighbors. So, you know, this gave us a sense of comfort and complacency. In addition to that, government had set up a committee, and they called it the super model. They came up with a modeling exercise, which seemed to have suggested, it was called a super model, and they seemed to suggest to the government that we have won the battle. They declared success, and they said, you know, wave 2 or nothing is going to happen. And so, therefore, there was this feeling of a sense of liberation, because the lockdown was pretty tough and rigorous. So people started coming out, they started partying, they were socializing. Trains in Bombay, I don't know if you know what it means. Millions travel and commute in those trains. Trains started, temples were full of people. And then we had that grand ceremony, which was supposed to be held next year, but they preponed it because next year is the election in that important state, politically very important state of UP. So they preponed it to this year and allowed millions of Indians to go, Hindus to go and bathe in that river. I mean, that became a huge super spreader. It was no brainer to say that that should not have been done, simply no. So the other modelers who had gone and they said that, you know, you have to be careful of wave 2, it is going to hit us badly, was set aside. We happened to believe in the supermodel theory that we were okay, and the middle classes were only too happy to believe that because they wanted normalcy to be restored very fast.
Sure. Ramanand, you've done a lot of modeling on this. I wonder if you could kind of enlighten us of what you think, why you think India is where it is today, and what is the trajectory? What are you predicting of where it's going at the moment? Well, first of all, how did we get here? Do you agree that it was complacency and they just let their guard down, or did something else happen? And where do you see this going?
Right. Thanks, Emma. Thanks for having me. Thanks, David and Chatham House for inviting me. So last year in March, on March 24th, India imposed a very harsh lockdown nationwide. And this was after, again, epidemiological projections, which basically said that there would be hundreds of millions of cases. A lot of people didn't really think it would happen. But the evidence shows two things. One is that in the case of a respiratory virus that is spread easily, especially in dense populations, that an earlier lockdown of the kind that India put in place was going to be very helpful. So countries that did early lockdowns were able to control cases, and countries that did late lockdowns were not really able to control cases. So if there was one thing that the Indian government did correctly, it was to put in place that lockdown, which was done when there were only 500 cases and fewer than 10 deaths. And it was a gutsy decision. It was probably poorly implemented in the sense that the migrant workers were not taken care of. There wasn't really planning that was done. And that really should have happened. But one can't fault the decision to lock down, because at that stage, India didn't have the testing capacity. It certainly didn't have the healthcare infrastructure. It had all of the hallmarks of being a place where COVID would really take off. And we sit here today where we stand, based on a lot of knowledge. But at that time, we had all kinds of, excuses that Indians are more immune than other people. We have, BCG vaccination. We have the summer heat that will kill the virus. We have hydrochloroquine. Any number of reasons why India was exceptional and different from other countries. Now, fortunately, that was not the advice that was listened to, and there was a lockdown, and the data very clearly shows that the effect of that lockdown was to bring the reproductive number down from about 3 or 4 down to close to 1, at points around 1.1, 1.2. And this is based on a very large COVID epidemiology study that we published last year, based on data from Andhra Pradesh and Tamil Nadu. And this year, again, we have more data, but all shows the same thing, that lockdown essentially saved India last year. But for that lockdown, India would have had the same kind of wall of cases that we see this year. Now, of course, the year went by. Of course, people don't really pay attention to the fact that projections are based on what you do with the projections. This is like saying, if you're overweight and then you lose weight, then your chance of being diabetic are much lower. And people say, well, but you said there would be hundreds of millions of cases. I said, well, if there were no lockdown. But with the lockdown, certainly it managed to bend the curve. But even so, India did have a lot of cases, and there was undercounting even back then. We had a peak around September, and then it started coming down. The ICMR's, the Indian Council of Medical Research, their own seroprevalence survey showed that infections to case ratios, reported case ratios, were between 26 to 32:1, which means for every reported infection, there were 26 to 32 actual underlying infections. And this was the situation in 2020. Now, come January, of course, people were asked, well, what's going to happen after this? And, I sort of, for my part, I think I underestimated, or maybe I overestimated the ability and the willingness of the system to lock down again very quickly, because having experienced the overrunning of hospitals in Delhi and Mumbai last year, not so much in Delhi, but much more in Mumbai, that we would have learned a lesson from it, that this was not a virus to be trifled with, that we had no special immunity from this virus, and that there would be a much quicker response. On that, I was wrong. The second was in assuming that the planning for the vaccination had happened as was being, portrayed in the media. I think, if you had asked anyone, I would have thought that India had all its vaccines procured through for this year. And it was a shock come February or March when we realized that almost nothing had been procured. And this was a shock. And the 60 million doses that India had exported were not really, humanitarian assistance for the most part. Most of these were commercial deals that had been done by the Serum Institute with other countries, because India had not bought the vaccine first, and they'd been sitting on a lot of vaccine stock, and most of these were not assistance, they were just commercial deals, and it was exported to about 70 or 80 countries. So this again was surprising and a little worrying. And then, of course, was the shock of actually having the messaging go off track with allowing election rallies without people with masks, of course, the Kumbh Mela. It is not as if these were the events that caused the second wave, but these events gave the perception to the common man who has no access to epidemiology, does not read journals, just observes what's going on. And the message to them was, don't worry about COVID, it's gone, so go back to life as normal. And people did do that. I was in Guwahati in February of this year, and this is in Assam, in the northeast. Literally, I would say probably less than 2% of people that I saw wore masks, less than 2%. Assam is one of the worst hit states right now, but back in February, which is just 3 months ago, nobody was wearing a mask. Why? Because that was the messaging back then. And the last part of this is also that there has been no preparedness of any note. Oxygen, which is I would say the biggest source of avoidable deaths in this wave, should have been prepared for, because oxygen shortages were not a surprise. They happen in Iran, they happen in Italy, they happen in France, they happen in the UK, they happen in New York, they happen in California. Now, what made us think that we were going to be different with respect to oxygen? And particularly for a country where a lot of people die even normally because of lack of oxygen. That was one. The second is the clinical guidelines were not based on evidence. And I would say even today, poor clinical guidelines have probably killed as many people as the virus itself. Hydrochloroquine is still on the clinical guidelines. Ivermectin is on the clinical guidelines. Remdesivir is there with very poor guidance on what really needs to happen. Plasma therapy, which the Indian Council for Medical Research had a very good study published in the British Medical Journal showing that it has no effect, is still, not off the guidelines. So this is inexcusable. I think Sujata is talking about the need for science, but even when the science is very clear, it's just unbelievable that this is not part of the treatment guidelines, because this is universally accepted that these things don't work. Why is hydrochloroquine part of the treatment guidelines? I thought we did away with this, with 50 odd studies that were published, last year. So these were three things that let things down. And of course, the virus came back, and people think that the virus came back with a vengeance. I don't think that's true. I think what really happened is that we chased the virus with a vengeance, and that's really what happened. It was an entirely avoidable situation, and the fact that India actually did so well last year, despite the odds, was something to have been proud of, and only to lose the plot in February or March of this year is really what is so disappointing about the entire thing. Now, of course, I think that the number of deaths is hugely undercounted. Today's New York Times has, of course, the estimate of about 1.6 million deaths. I think that's a bit high. My best guess would be about 1.2 to 1.5 million deaths, somewhere in that range. But people are not being tested. They die. They don't count as a COVID death. People who don't even show up at a hospital, they're only counting hospital deaths. Those don't count as COVID deaths. And it is not about it's not about whether the counting of deaths has an important value because it communicates seriousness to the public. If you don't communicate data to the public, they don't take it seriously. We've seen this with HIV. India did a great job in HIV, as did Uganda, as did Thailand, because there was transparency. South Africa and Botswana did not do well with transparency, and therefore they suffered much long with HIV. So it is not as if India does not have experience with vaccination, does not have experience with procurement, does not have experience with dealing with pandemics. It is just that the plot was lost, and really for, I think, no reason other than the need to manage the PR of the disease than the disease itself. And that's really what is so sad about the whole thing, which is India was on track to do so well with COVID, and that was not to be.
Do you think, Ramanan, if India had hung on to its vaccine supplies, or if it had a huge supply of vaccines last year, that would have made a difference with India making vaccines for much of the rest of the world? Is it now paying the price for exporting those doses? I mean, would it have even if you did have vaccine supply, would it have had the infrastructure to have delivered it in the country, even if you had the supply? Basically, would better supply and delivery of vaccines have averted this second wave, this problem? Or is
yeah, first of all, the delivery is not the issue. India can deliver 5x the amount of vaccines. That is not the rate limiting step. I don't know if that particular 60 million doses would have made the biggest difference, because that translates to 30 million more people vaccinated, which is again a small number. But I think what India should have done is invested, like the US did, in some sort of Operation Warp Speed to massively increase the supply of vaccines and the production capacity back in September itself. And the failure to do that and to treat this as a business as usual kind of vaccine procurement, this is how India procures vaccines for childhood vaccination. But this is not a normal time. This is an unusual time. And it would have been entirely worth it for India to sink $5 or $10 billion into increasing that supply. And it would have put India in a very different place right now. To have had something like 15-20% of the population vaccinated would have made all the difference. So that's why it is frustrating, because all the steps we're talking about are things that are within India's ability to do. And remember, India is a 2 trillion GDP economy. $10 billion is chump change for this country.
And as far as I'm going to move on to David now. Do you think that what's going on in India is particularly worrying relative to what's going on in other parts of the world that are really having a tough time now, Brazil or other places? Is there something special about India that should cause the world a particular concern? I mean, I'm just wondering, why is there such a focus on India compared to other countries? Because it seems there is. I know we have a variant that was first discovered in India, but is there something particularly big implications of India not managing this well, David, compared to other countries? Why India?
Emma, during this pandemic, the press has gone from country to country. They've looked for where the cases are most and where the problem is worst, and they've gone there and they've reported on it. And now they've stopped in India after having left Brazil. So the press is constantly bringing people's attention to where the problems lie. India, though, is, as Ramanan said and as Sujata said, is an incredibly important country in the world. And it's got a good portion of the world's population, and a good portion of the world's economy is being generated in India. So it is important for that aspect, just as is the US or as is Brazil or the United Kingdom in many ways. So it's not so much that India is more important than other countries. At present, that's where the focus is. But if you want to look at importance, it is important in the world, as are many other countries. I don't know if that answers your question. I think we've had an excellent summary from both Sujata and Ramanan, and maybe we should really dig in deeper with them, because they really understand what's going on in India right now.
Well, I wondered, Ramanan, maybe, or either you or Sujata, on the economic front, and related to Ramanan, my question to you on where do you think this is headed? Is there a risk that this could really damage India's ability to function, or is that really a catastrophizing thought? And where is this going? And is it in danger of failing as an economy, or is that really a bit out there, a bit exaggerated risk? And if it is, what might be the implications of that geopolitically and economically?
I don't think any country is done with, until it's done with COVID, that can actually go back to building the economy. And I think that is true for every country, and it's true for India as well. We just have to be done with COVID, and we've got to be done with it through vaccination. And the vaccine supply problem does need to be solved. That is the fundamental one in front of us right now, which is why the foreign minister is in Washington right now trying to figure out a deal to see if they can bring the US mRNA vaccines to India. Now, the Indian economy obviously will not recover at the rate that it was expected to, but I have no doubt that once COVID is dealt with, India will come back strongly. But we have to be done with COVID first.
And I have 2 points, Emma, for your consideration.
Sure.
One is, no one is safe till everyone is safe. That's a nice thought to think of and reiterate again today. But I also would like to, I'm reminded of a story way back in 2000. I don't know, David, if you were in WHO at that time, but that was a meeting to review polio eradication. And India had not, 2000 was a goal to be achieved in India along with another 14 countries. We had not achieved the goal. And Donna Shalala, as Secretary of State Health from US, had come for that meeting. And she told me very pointedly, I was with the minister, and she told us very clearly, saying, don't think that we are pushing you to achieve the eradication goal because we love you. I mean, so candid as that. But because you have polio in your countries, we Americans have to spend $400 million on vaccinating our children. So there is a whole amount of self-interest involved. I mean, it might sound brutally insensitive, but it's a fact. So, if you ignore 1.3 billion people and say, doesn't matter if they are dying or they're with B1617, we'll come up with another 3 mutant strain and happily send it to UK and USA. All your vaccines won't help you. So, it's something that this is a moment of solidarity where we must realize that the world is much, much more interconnected than it was before. And we cannot allow a large economy. We are the 3rd largest economy in the world. For India, I mean, if you talk about India specifically, to fail, I mean, we are strategically poised in the middle of the world as we would like to believe, but it's between East and West. And, we just cannot allow the huge market that India is to allow to fail economically. And finally, if India is helped at this moment, with the patent waiver, which is pending for everyone's consent, it gives the world a chance for us to be able to come up with generic medicines and much more affordable and cheaper vaccines. I find it appalling that the vaccine companies today should be thinking in terms of profiteering at this moment, selling $20, $25 a dose, when they're not even able to assure us whether this immunity that this dose gives will be there, at least valid for 1 year. So, for a substandard, untried product, which they produce, they're making money. I think India should be allowed. We supply 60% of childhood vaccines around the world. And if we can get this waiver and our companies are incentivized, we certainly can produce it at a much more affordable level, the way we did for HIV/AIDS, and save the world's poor. I don't think US and the few countries in the West, in Europe, can take the whole burden of vaccinating everyone at $20 a dose. So, I think we need to look at all these factors and take a good view, because I'm saying this because the patent waiver is with your part of the world, and I hope a quick decision is taken and a much more sensible, reasoned argument is made to adhere to that and agree to that request, which is affecting the world as a whole.
Yeah, I mean, that's the really hot question at the moment, and
yeah,
it's interesting to see how that pans out. I'm going to move to audience Q&A now, questions, and I'm going to start with one from Richard Cash. Sorry, it's a bit of a difficult one, bit of a challenging one. This is from Richard Cash, and he says, the lockdowns in both Bangladesh and Pakistan were far less severe than in India, yet both have mortality and case rate less than half that of India. Please explain. Wouldn't a well-crafted mask-wearing campaign have done just as well? Ramanan, you're smirking. Let's hear it.
No. I knew Richard would throw a curveball like this, so
Okay.
So, Richard, as you know better than I do, the whole idea behind having that lockdown was to signal to people that they should protect themselves at a time when the data were not there to today, if I go outside my house, and of course you've been here, so you know what it's like outside here, everybody's wearing a mask, not because there's a cop around, but because they know that if they didn't wear a mask, they'd be looking for a hospital bed in about 10 days. So that awareness exists today, which did not exist last year in March, because how would people believe a disease that has killed 10 people? And how would they respond to that by protecting themselves? So I don't think a national mask campaign would have worked at all. Second, if you look at differences within Indian states which look at case reports and testing, the biggest determinant of cases is how much they test. So I would not take Pakistan or Bangladesh as really, their numbers of infections are low because they're reported infections, and their reported infections just reflect inadequate testing. Their number of deaths reflect inadequate testing. You'd find parts of UP where deaths are probably zero, right? Doesn't mean that the deaths are actually zero. And so the best way to not have a pandemic is to just, throw it under the carpet and you don't have to worry about it, which is the approach taken by some other countries. I think that what we do in Tamil Nadu or Andhra Pradesh or Maharashtra or Kerala are really the ways in which we should do it, which is it appears as if things are worse, but these places test at very high levels. In fact, Andhra Pradesh and Tamil Nadu actually have tested at levels which are close to that of the United States, during the early part of through to last June or July. And so I think that's the reason why, things in Pakistan and Bangladesh are not what they appear to be.
Emma, if I may just say a bit, as a rule and as a principle, I don't know what David thinks and what Richard feels, but the whole business of lockdown is anathema to me as a public health strategy. I mean, unfortunately, China seemed to show effectiveness of it, and so the whole world is following it. But a time has now come in India where we cannot afford this lockdown as a strategy. Last year, we made a monumental mistake of when, as Ramanan said, we had just 500 cases and 30 deaths. The whole country was brought under lockdown when it could have well been contained by identifying the hotspots and just contained it rigorously over there. So, with the result, it became so severe that we let loose and triggered a humanitarian crisis from which we are not able to recover. Hunger has increased. Unemployment has increased. There's a 7% shift from low middle class into below poverty line. And this is a huge price we are paying. Today, hunger, that's one problem we have resolved in all these years. So there is this empowerment. I don't think that lockdown, just to save a few lives, you put so many millions others at the stake. So I think a much more calibrated policy, much more nuanced, much more refined policy mix has to come, where we have to think of saving lives, but also look at livelihoods by really doing much more. As again, I come back to my favorite theme of data, mapping where increase our testing phenomenally more and identify the positive cases, map them, which Kerala does beautifully, and Tamil Nadu, I think, is also doing, and then see where the hotspots are and really get after that to see whether we can contain the infection within that perimeter of that hotspot, rather than just go around doing these lockdowns up and down and, reopening and locking down. It's not something that is an affordable or a sustainable model for a country which is very fragile like India. We have 94% informal workers, and we have to think of all those issues too.
Yeah, Emma, if I can just respond to that. I was just going to say, I don't disagree with Sujata, but the problem was that, and I would have certainly preferred the strategy that she's espousing. The problem was that testing was kept artificially low all the way through to March and April of last year for no other reason than appearing to hide an epidemic. India has a capacity to do vast amounts of testing. First, it was just, to National Institute of Virology. Then it was just to government labs. Why? We've got private labs, all across the country. So I think I don't disagree with anything that what she says, but you cannot simultaneously manage the PR of an epidemic and the epidemic at the same time. You have to choose. And you have to face the epidemic. And if you want to do PR, you're going to lose the plot on the epidemic.
David.
Yeah, and I would just add that, locking down took away the need for individuals to do their own risk assessment. Yeah. It just locked them down. It forced them into a situation. And when they were let free of that situation, they didn't many times have the knowledge or the capacity to understand how to do their own risk assessment. That was shown in the UK.
Absolutely.
It was shown in many countries. And as a result, people ended up leaving lockdown, not wearing a mask to protect others, not knowing how to protect themselves. And so they just took up life as normal again after the lockdown. What's happening in the UK now and in other countries is that they're trying to get the people to take the responsibility, because it is a personal responsibility. It's a responsibility of each one of us to contribute to the control of this pandemic by doing our own risk assessment and modifying our behavior. Because you can have a variant which transmits very easily, but it still takes behavior, poor behavior, to make it transmit. It won't transmit if behavior is the way it should be. So I think all countries, including India maybe, and Ramanan, I think Sujata might agree, Ramanan, you might not, that these lockdowns really, in the end, have been detrimental many times to long-term sustainability of a response to the pandemic.
Yeah.
I don't disagree with that at all. I just think that we got off on the wrong foot, and in fact, I wrote an op-ed just 2 days before the lockdown. Even though I did call for a lockdown, I said, "How about we do state-level shutdowns?" But by that time, I think the trigger had been pulled on it, so it was what it was.
On that question of what you said, Ramanan, about you can't manage the PR of an epidemic and the epidemic itself at the same time, there's actually a question from Anna Purna Sharma, who is asking, rural India already is in the middle of a calamity. It's just hidden by the government, especially UP. How can the government be enabled to admit that people died? So I guess, well, how can we get this out in the open and get transparency and be able to tackle the problem rather than sweeping it under the carpet? And do you agree, first of all, that there's already a calamity in the rural areas?
There's a huge calamity in rural India, and in fact, the anecdotal evidence is very clear, the media evidence is very clear, and it's just that I don't know what to say. I mean, at the end of the day, governments are democratically elected. They do what, they're accountable to the people at the end of the day. And people are not going to vote on the basis of the total death count. They're going to vote on the basis of when they needed oxygen, when they needed a bed, if they needed help, did they get that help or not? And I think that many people in UP and Bihar have found that they have not received that help when they really needed it. They have faced the brunt of a weak and unprepared health system, which, even in the best of times would have done poorly, but this time was just completely unprepared, even though it had 1 year's, full notice. And it is quite something to, I think we've all experienced this in these last few weeks, thankfully not the last 10 days, but before that, I'm sure Sujata has as well, of receiving endless messages for people begging for a bed, begging for drugs, begging for oxygen. And we're in the cities where we have access to resources, we have access to so much. Can you imagine that person in rural India without any of the connections that we would have, and just choking to death without oxygen, something as basic as that? So an epidemiologist would want to know what the total death count is, because then we're interested in the science of the disease. But the average person doesn't care about the total death count. That's irrelevant to them. They want to know what happened to their family, their mother or brother or sister or father. And that's the story of COVID, which is that it has left a deep mark on people's psyche. I've seen that. I've been, outside ICUs when people have died. I've known people who died. And it is, it's that which is really going to be the, that's what's going to live behind as people's memory of COVID, having lost both their parents to COVID. So many of these people. There are states that have set up facilities for COVID orphans. There is such a thing, COVID orphans. People dying in their 30s and the 40s. And, how can we forget something like this? This is like, someone who lived through the 1918 flu pandemic when the excess mortality was much less than during COVID, because their baseline of mortality was already pretty high, so the excess mortality wasn't as high. I think this is an event that will take years, if not decades, to really, recover from in some ways. And I think we'll do the death counts, but I think the psychology of this, of what this leaves behind, is going to be is going to last for a long time, I think.
Yeah, that was going to be another question of what can we look forward to on this. But before I do it, I'm going to go to the most upvoted question at the moment, and it's from Charles Clift. And I think maybe, Sujata, for you, why do Indian doctors seem to use a multiplicity of drugs for COVID treatments, including those that have been demonstrated to have little or no benefit? This is something that's come up about all the treatments that are being used and have been proven not to be right. Why is that happening? And what's at play to make this such a big feature?
One policy gap that I can see is, and which I'm unable to understand and inexplicable to me, is why the ICMR or the Ministry of Health, whoever it be, did not come up with a detailed treatment protocol, kept updated. Because after all, this was a virus which no one understood around the world, and everybody was experimenting. Let's face it; it's not as if we knew all about it last year in March. So this was something that people were working on. But even so, they could have come out with this advisory, which is what is normally done. And why they didn't is something that I'm unable to answer clearly. But that is where they have to do. They need to come up with a treatment protocol and make it mandatory for all doctors to follow. Now, what am I to say? Why do they prescribe remdesivir? Because it's a short supply. There's so much of black marketing going on. At the lower level, I don't mean the big hospitals, they get a kickback from the people who are black marketing it. And so there is a whole vested interest that's involved. And then even though it may have nothing much to do with the treatment outcome, they will still administer it on the patient. So these kind of things happened. There were also genuine misunderstandings, because partly I would blame the media channels, which every day bring in specialists from all over the place, and each one would give their own experience of the drugs they've used for treating a patient. And the patients and the people listening to it would pick it up and begin to demand those drugs to be used for their treatment. So, this kind of situation has developed, and I think this needs to be contained. For example, of late, this whole business of CT scan as a diagnostic tool has been coming up, where the tests are not being able to diagnose. RT-PCR is not able to really get the virus, detect the virus. The report comes as negative, but every clinical symptom shows and suggests that the person is infected. So then he's marched off for a CT scan. So the conditions under which you order for a CT scan should have been very clearly specified, and a lot more training of our doctors on how to handle, because I do believe that 95% of our doctors were struggling and doing their best. It's not at all my case that the one and odd fellow who was trying to exploit the situation was there. They really, really worked hard. And we can only salute our doctors and nurses for what they have gone through. It's amazing. So it was incumbent on the government to have come out not only with guidelines, but also provided telecounseling and also training through the telemedicine route. I'm afraid they didn't do enough of that. And why I'm saying this is that's what we did for HIV when the medications and the dosages kept changing with new evidence and new knowledge. And then we had this kind of interchange with the private sector and with the public sector and kept updating them. And I think the demand was much, much more in this particular case, because almost every day there was a discovery that this is not useful and that is not useful, this is not workable and that is not workable. I think this ought to have been addressed, and I hope it is addressed very quickly.
Okay, so thank you for that. This is probably one for David, maybe to start with. Mayank Gupta, what is, going back to the black fungus, what is the root cause of increased incidence of mucormycosis, the black fungus, or other opportunistic fungal infections epidemic in India? Is it underlying health issues, such as uncontrolled diabetes or obesity, or dirty tubing of ventilators and aircon ducts, or of cocktail of potent and unnecessary drugs prescribed in and outside of hospitals. What do you think is driving this? And while you're at it, if you could say, is this particularly worrying, or is this just something that happens that will pass? Is this a particularly dangerous complication of what's going on here?
Yeah, thanks, Emma, and thanks, Mayank. Yeah, mucormycosis is a fungal disease, and it's an opportunistic infection. So it occurs in people whose immune system is diminished, and it occurs because there are spores that are formed, and those spores then transmit the infection to others. These spores could be in a hospital setting, they could be in the community, they could be in many different places. But because the principal treatment for this infection, for SARS-CoV-2 is dexamethasone, it of necessity decreases the immune response, and therefore people are more susceptible to this infection. So opportunistic infections look for the opportunity and they take it. And that's unfortunately what's happening with this infection, which is present in India, which may be present in some of the hospital or treatment settings, and which can transmit easily by spores and therefore cause disease in those who are immunosuppressed. But others may want to add to that. Living in India, Sujata.
Yeah, can I just push you to say opportunistic? What opportunity has been created here, specifically?
The opportunity is the decrease in immune response due to the dexamethasone in patients who are being treated. And it's also the fact that it's present in the environment, in possibly hospital settings, and therefore it has the opportunity to infect those people who are seriously ill.
So IPC, infection prevention control, cleanliness of hospitals, is that part of the?
It may be part of it, but there's no evidence yet of where it's really transmitting. And it would be wrong to say that, but IPC, infection prevention and control, is just a basic for all health facilities, whether you're able to transmit other infections there or not.
Okay, Raman and Sujata, do you want to come in on this and also say, is this a huge danger, or is this a kind of minor thing that we really shouldn't get too het up about?
Well, I would just say that I don't think in this pandemic, the way it's evolving, we should take anything lightly. If you just measure only by caseload, okay, we have 1,200 cases or so of black fungus, but that's not it. Now we found white and yellow. So, I think every infection, every case, that new presentation must be taken very seriously and researched to see what exactly are the causative factors, and remedial action should be taken. But what we are hearing is it's diabetics and also infected tubes used for oxygen, administration. That could well be, particularly in the northern states, where, if oxygen supply, you see the kind of environment in which there was a huge rush of patients and beds were few. And in fact, there were hospitals where a bed would be there with 1 or 2 patients, and there'd be a line in front of the bed waiting for one of them to die so the other one could hop on or die or get well, whatever it be. So in those kind of situations, I don't know how much of the cleanliness infection control measures were possible at all. It was just kind of constantly being on the ball. So I think there's a lot of, again, work that needs to be done to say what are the causative factors once we get over the hump and control the situation, and to take remedial action so that it doesn't happen again.
So we've pretty much run out of time, but I want to squeeze in a one-liner, Sujata, really, really quick, on where you think or fear or hope that the Indian epidemic is going. Where do you think it is going? Are you pessimistic? Are you optimistic? Really, really quickly.
I think I'm cautiously optimistic because I do think that finally the government has got on top of the situation where vaccination is concerned. They've got a very rude shock with what devastation wave 2 has caused. So, there's no getting back into any kind of complacency now. And that's a good thing. I mean, that they needed the jerk and they got it. So I think now with more vaccination being aggressively, though I do want to say upfront that I don't believe that the vaccination is the panacea. It's just one of the most cost-effective and cheap methods that we have
Okay.
to try and contain the infection, but also mask wearing and so on. So
Okay, that's it. I'm going to give Ramanan the opportunity also. Ramanan, while you were offline, I said, we've run out of time. I've gone over actually a bit naughty, but I'm going to give you a one-liner opportunity to say, as a wrap up, your final word on where you think the Indian epidemic is heading. Are you optimistic, pessimistic? Where is this looking like it's going to go? Briefly.
I think India's learned a lesson from the second wave. Hopefully won't lose its plot for the third. And hopefully will fix the vaccine supply. And that's really the only path out.
Okay, great. Well, thanks for saying, and thank you both for really great insight into what's going on in India. What are the drivers? What are the issues? And I think great conversation between the three of you. And to the audience, I thank you for your time. Thank you for joining us. I think this was a really great, deep conversation. There were loads and loads more questions that we could have got into. So I'm sorry we've run out of time. And thank you all for joining us for this pandemic webinar, and wishing you a great rest of the day, evening, wherever you are. Thanks so much.